And we are live. Excellent. Well, happy Wednesday evening. If you're live, say hi in the chat. I'm going to let you know about our guest. I'm Sarah Merritt with Lifestream Health Center in Bowie, Maryland, where we're working to make pain management more caring, accessible, patient-centric, and evidence-based. And I have today Dr. Samantha Benjamin-Allen, who is actually a native of Washington, D.C. and grew up in Prince George's County and is a medical doctor. And I'm just thrilled to have her here today with us.
Thank you for having me, Dr. Merritt. It's a pleasure.
Yeah. Well, so you're a native of the Prince George's area, and you are working as a physiatrist, and you have an interesting, unique role. And I'm going to put maybe your Facebook page for starters here in the chat, just so people can see who you are and what your business is. That Dr. Benjamin-Allen is able to provide care in home for
Yes.
certain patients. Tell us about what you do.
Sure. So, as you mentioned, I'm a board certified physician in physical medicine and rehabilitation, and I am passionate
Awesome.
about seeing my patients thrive no matter their circumstances. So, I am on a mission to help inspire, encourage, and motivate people to see the possibilities that lie ahead, no matter their disability or, what tragedy has come their way. In the midst of their life that has just caused a significant decline in their function and ability to
Mm-hmm.
enjoy a good quality of life. So I started my practice, Freedom Wellness Physiatry, to help fill or address the gap that I noticed in people who would suffer from chronic illness or trauma or just a prolonged hospitalization that was a little complicated and then be discharged either to a facility or home and suffer unnecessary decline, maybe because caregivers didn't have the right guidance or they just had problem accessing the healthcare system, or maybe even the insurance company started denying their rehab, therapies were cut
Mm-hmm.
based on their
Mm-hmm.
limitations. And unfortunately, they just suffered a necessary decline. And I thought it'd be a great thing if the provider could come to them and help meet them where they are, especially for those who
Mm-hmm.
are debilitated and find it difficult to get to a doctor's office. If a rehab physician could come to them and help direct and manage their care plan, and partner with the caregivers and help them get through this process, they could do so much better. So
Yes.
that's kind of what inspired my practice.
Yeah, and freedomwellnessphysiatry.com. That's exciting. I'm going to share your site here. Um, and so I literally had this conversation with a patient this week where a woman who has TPN, total parenteral nutrition, so she's not taking food by mouth. She's
Mm-hmm.
again, getting food through a vein. And she was really just, saying how challenging it was for her to even get into my office for a visit. And so we talked about, how we could help her. Is it possible to do some home visits? Now, I would share, like, in my practice, we just aren't set up for this, and most of the medical system like doesn't do. But I feel like this is like an emerging area for
Definitely.
more home visits, and I'm interested to know about it because I don't have any really knowledge or background in it. But I can share also, I have an acquaintance who's a physical therapist that does like at home PT. And so for a physician friend of mine whose father needed physical therapy, they utilize this in home PT where the person comes to you for convenience and for mobility of the dad. And they had this great experience.
Definitely. And I've seen it firsthand. I worked with a
Hmm.
woman who was in a skilled nursing facility for, well, her whole course basically was 2 months, from hospitalization to the skilled nursing facility, and she declined
Hmm.
so significantly. The family decided to just take her home and figure out what they could do at home because they were scared she was going to die there. And they called me and
Yeah.
said, "Can you lend us some advice from your expertise on what we can do here, because we're not really getting anywhere otherwise, because she's so debilitated and she's become completely dependent stage 4 ulcers in
Mhm.
multiple places. She's getting a tube, like you mentioned, you had a patient on TPN. She's
Yeah.
getting food by NG tube. It was just a really terrible situation. And I went there, I assessed her, I gave them my recommendations. This is what you need to do with her daily. And in 6 weeks, she was up talking again, eating. It was amazing. And I said, this is sorry, I think my mic went out. But
It did, but we're back.
yes, I'm back. So I was just amazed, and I said, people really need this, and I'm happy
Mhm.
to serve and help. So
Yeah.
definitely, it's emerging. And if you look at the statistics, the elderly population is going to outnumber. So basically, 65 and older age individuals are going to
Mhm.
outnumber those 18 and older by 2034. And the caregiving
Wow.
experience is becoming more prevalent. So there are a lot of people
Mhm.
taking on the caregiver role, whether it be for their parents or other family members or loved ones. And this has been a very
Mhm.
challenging time in healthcare in that regard. And if you just look at the amount of time and cost that is put into caregiving at home, it's actually cheaper when you have some in-home services for these type of cases, because the
Right.
hospitalization is so much more expensive. Um,
Yeah.
Centers for Medicare and Medicaid put out a study, and you save 30% in cost when you have a home-based program that's quote unquote like a hospital in-home program. So you have a physician and you have a team who's working with you at home. And in terms of caregiver savings, caregivers spend 13 hours a month just doing research on the disease process of who they're caring for, trying to
Yeah.
coordinate physician visits, trying to deal with financial matters regarding the case. And then when it comes to work days lost, 6 days in
Oh
a week
yeah.
are spent doing ADLs. So that's feeding, dressing, grooming, trying to walk them, get them out of bed.
Mhm.
And then 13 days out of the month are spent doing IADLs, which are things like shopping, getting food, preparing meals,
Mhm.
paying the bills, trying to manage trying to manage their finances, make sure everything's in order. And
Yeah.
you would cut out a significant amount of lost work days too if you could have a physician come and assess and direct the care and help manage the situation so that you can have a much better outcome and less caregiver
Yeah.
burden. So it's a good idea.
Yeah. Yeah, no, and I absolutely buy it from a holistic perspective, right? That if we can somehow look at us as all connected and that the lost productivity and the cost of that hospital visit, yeah, it's negative for
Exactly.
everybody. And so if
Yeah.
the ways we can find people to support. But I guess is one of the challenges still, I mean, are these visits covered under insurance yet? Or, are we hopefully working toward that? How how does that work? Is this because the system's kind of fragmented and in
Yes.
my practice, it makes for challenges to provide that holistic care.
Yes, and it is very fragmented, and there are not a lot of home-based programs that are covered by insurance, unless it's ancillary services like therapies, like home PT,
Okay.
home OT.
Home
But
PT.
even those are
And you have to
usually
qualify
limited.
for it. Yeah.
Right, you have to
Mhm.
qualify for it, and also it's limited. So maybe you'll get 10 sessions a year, or depending on your plan, it could vary.
Yeah.
And from a physician perspective, there are not a lot of plans that are doing physician home-based payments. So my practice, for
Mhm.
instance, is concierge-based, which is basically a
Okay.
membership style practice. So patients would pay a yearly fee, and I'd be able to see them, up to 10 times a year for an extended time period, usually 1 hour,
Mm.
to really deal with the
Mhm.
complexity of their case, go through the whole person, perspective and
Mhm.
approach to caring for them, mind, body, spirit, reviewing the medications, looking at the home environment. What can we modify to make things easier? How's the diet? Looking at the nutrition. So you don't really have time to do that in the traditional setting where you might get a 15-minute visit and you're usually seeing a more high volume of patients. So
Right.
a little challenging in the model that we have now, but I think the more this catches on and people see the value, I think
Yeah.
insurances hopefully will be more willing to
Yeah.
pay for these services.
Yeah, but that's right. Because if they're, and frankly, even like a, a for-profit or a nonprofit insurer has to see the wisdom of it if it can help avoid hospitalizations for, again, this isn't something that every patient needs, but for those people who are recently dehospitalized, recently out of a rehab center, I can see that those are patients that are really, at risk to have, problems with their outcomes if they can't be managed and assisted.
Exactly. And I'm glad
That's
to hear
great.
you're offering some home-based services for your patients who are in this type of situation too. So the more people
We're
do
figuring
it,
it
I
we're
think it's a good
figuring it
thing.
out. Well, and really what we've got at this point in my practice is a little bit of telehealth.
Mhm.
We can check in. Um, is that part of what you do at all? Or I know there's value obviously to seeing the person in their home and their environment, right? So I guess
Yes.
is there some of both, or is it exclusively in person at the home for you?
No, it is not exclusively in person. I also offer
Mhm.
telehealth visits for the convenience of the members,
Yeah.
but I definitely do my first visit in person. There's no way around that. So
Yeah.
the
Yeah.
consultation has to be in
Understood.
person, and I prefer in-person follow-ups, but in some cases that's not necessary, and a telehealth visit is fine.
Yeah. Yeah, and so in our practice, we're able to do certain things on follow-up, but, like for a controlled medication, controlled substances, that's not something that's able to be done on a televisit, really anymore since the expiration
Right,
of the, emergency declarations around the pandemic.
right,
Um, but what I have done is I have, pointed patients in the direction of resources. I have definitely pointed patients in the directions of resources for, home-based providers because I do think like for physician visits that can be a big deal because I'm just coming to be aware that that's a thing. And then also secondarily, as you mentioned, home-based physical therapy. Um, in our practice, sometimes if we have patients that are very elderly and feel like they can't get to an appointment,
right,
that home-based physical therapy is something we're absolutely willing to order. And then the therapy usually goes and makes that assessment to make sure they qualify
right,
for the services. It's been
right.
my experience.
That's right. So the therapists who do home-based therapy, they come in and make their assessment, and they'll do a program. And
Mhm.
in contrast to the inpatient rehab experience, where there's the physical therapist, occupational therapist, speech therapist, the whole team is there, the
Yeah.
dietitian, the
Yeah.
physician, the nurses. We all work together to help optimize the health outcomes of our patients. And what
Mhm.
has been found as well in the home setting is when a physician is directing the home-based therapy program, the outcomes are also much better. And that is something that's
Mhm.
lacking in today's system. Is usually the
Right.
home-based care is entirely left up to the um, therapy team. And sometimes there are cases that are so complicated, you might walk in and say there's nothing really for us to do. And that's not always true. So it's nice to have that
Mhm.
added input from the physician standpoint to suggest exercises and programs that might work for somebody who's, for instance, minimally conscious, who looks like you can't really do anything with them. But as we know,
Mhm.
there are coma recovery programs and certain things that you do with somebody who's really at a low state that can still help to bring them back to a place where they are conscious and interacting with you, and gradually bringing them through the steps to get them to a more independent state of being. And
Wow.
those are some gaps that also occur when the home-based program, when there's not really uh, a team-based approach with some more
Mhm.
insight or suggestions to help somebody who's really so severely debilitated. It looks like there's nothing that you can do. So
Yeah. Yeah.
it's helpful for that. Yeah.
Huh. Yeah, that's so interesting. Well, and I can imagine a scenario where it sounds like a lot of the patients that you serve have been recently in an inpatient rehab. Is that correct? That's usually
Sometimes.
the type of patient that you're visiting with. Okay, so not necessarily. They might just
Yeah,
be
sometimes
referred
it's
by a
more
primary
likely
care doctor.
somebody who ended up going, they were discharged to a skilled nursing facility,
Okay.
and or they could have had an inpatient rehab experience and then
Hmm.
uh, and then transition to skilled nursing, based on maybe their support system or their needs in terms of their physical limitations. For instance, if they were living alone before their illness and they were made non-weight bearing and they were going back to a home where they're supposed to live alone, that might not be a safe discharge. So then they would get sent to a skilled nursing facility. But even if there was a opportunity for them to have caregiver support for a couple of those
Yeah.
weeks at home, it would be to their benefit because people do thrive better at home, given the right support. And we already know there's a shortage in staff and facilities, especially since COVID.
Hmm.
So that's another growing
Right.
issue. Yeah.
Yes. Yes. Yeah, I think for sure if a person has an ability to have some help at home, I can imagine that most people would rather be able to be in their home if that's going to be possible for them.
Yes. And a lot of people would like to help and they just don't know what to do. So it ends
Yeah.
up not being an option because they don't have the guidance.
Hmm.
And if that support was there, for instance, somebody who was living alone but then had a bad illness, and maybe their son or daughter wanted to take them home, but they said we don't really know what to do. It'd be nice if they could get some physician directed support and say, this is what you need to do, to outline it and give them the reassurance and the recommendations that will help them along that journey so that they can
Hmm.
do it at home. That's preferred. I know some
Yeah.
cases that's just not possible, but in
Hmm.
others, there are people there. They just don't know what to do, so they say, I guess we'll just put them in a facility because we have no idea."
Right. Or just
So,
we can't do this as a
right,
reaction to I
right,
don't know what to do. I've definitely
exactly.
observed that type of reaction with a challenging patient situation, because if you don't have any training in how to help someone transfer or how often you might need to check in on them or whatever the other duties might be.
Exactly. And that's one of the benefits of inpatient rehab. The places I've
Hmm.
worked, at least we had family meetings and we would
Oh,
train the
mhm,
family so that when they went home, that transition would be so much less stressful and more manageable. And a lot of people don't get
mhm,
that, especially if they're just being discharged from a hospital or maybe they're in the ICU, went to a step down and then went home. They don't get that experience of someone training
mhm.
their family member on how to do this at home. And then that decline ensues. And so in some cases, it's, premature mortality or
Yeah,
early death.
yeah,
And
yeah.
it's really sad. It's really sad.
Yeah, I mean, it's kind of heavy like that, right? When you think like no, this is like a potentially a life-saving intervention if you keep someone able to maintain their mobility, maintain their independence. It could literally be life-saving.
Definitely.
I think too about my patients when they are post-op, certainly after serious surgeries like a knee replacement, patients might go to an inpatient rehab, depending on their home situation. We've seen that.
Yes.
My father, in fact, actually went to an inpatient rehab after a knee replacement. And really just because my mother just wasn't like she was living in good shape, but just didn't feel like she could assist him,
Handle
and
it.
that may have
Yeah.
even been an education deficit, right, of
Right.
not knowing how to help. But I know that I think about patients with um, post surgery because that's a lot of who I see go to a rehab facility for a short term. How
Yes.
do you work with those patients, or are there ways that you work with those types of patients?
Yes. Usually patients who go to inpatient rehab after surgery for hips or
Hmm.
knee replacements. The reason is either because they are complex in terms of their medical history, or they don't
Hmm.
have the support, or the person who's at home does not feel they have the education or the understanding of how to
Hmm.
take care of them. And their insurance
Hmm.
provides coverage for them to get rehab days. So I always tell anyone I talk
Right.
to, when you get insurance, make sure you ask how many inpatient rehab days they cover, if at all, and what their home
Hmm.
coverage also is, because you never know what can happen in life. And when you need it, you would wish you had it if you had known.
Hmm.
So I always tell people to ask that. But usually it's those cases where people have a complex medical history, or they don't really have um, the support at home when it comes to the strengths physically of the other person, or
Hmm.
just the knowledge of how to care for them. And they will go to through a rehab program, and then it'll make it much easier for the family. But I also work with joint replacements. And in this
Hmm.
scenario, it's usually people who've had complications with their joint replacements. So
Hmm.
there's infection, there's
Yeah. Yeah.
infections, um, or they've had multiple surgeries and end up severely, debilitated over the course of that experience. And those are more so the
Hmm.
people I would see in this type of setting. But I also work with
Hmm.
joint replacements, just as I would in inpatient rehab. But
Yeah.
they are less of the ideal in this style of practice.
Okay.
Yeah.
And why do you say that? Because they're just a different trajectory
Yeah, the trajectory of their
of their
recovery
recovery.
is usually
Uh-huh.
better. But again, for the
Hmm.
more complex individuals who have, a lot of comorbidities, the
Hmm.
diabetes, the high blood pressure, morbidly obese, even other deficits prior to having that surgery, where
Hmm.
they might have a rotator cuff injury, or it's really complicated. um,
Hmm.
those are more so the people I would see in a home setting. But
Hmm.
standard joint replacements, also, if it's the person who maybe has transportation issues and they can't get out
Hmm.
to go to
Yeah.
therapy, and their home therapy has expired. Maybe they've used up all of their home therapy and they still have a lot of potential, but they don't have any more days. And they would like that
Mm.
support and direction to get them where they can be. That's where I would come in.
That's great. That's great. That's great. Um, Very good. Uh, so we've talked a little bit about the importance of home therapy and home, I guess, just home services, right? For
Mhm.
patients who are needing help with rehabilitation. Can you share an anecdote or a story about one of your patients where e- either something that meant a lot to you or you where you felt like you made a big difference?
Sure. One patient that comes to mind is a young woman who had a brain hemorrhage. It was a
Hmm.
spontaneous hemorrhage, a very tragic event. There was no
Mm.
precursor or um, premorbid state that contributed to it that anyone could find. All her tests didn't really prove a reason.
Hmm.
Outside of, she was going through a stressful time period, but there were no other
Yeah.
markers or, prior aneurysm to say, this caused it. It was very
Yeah.
sad because it left her, she was not talking initially. So she had aphasia. She
Hmm.
had torticollis, so her neck was stuck in this position.
Hmm.
She was not walking, and she worked with me and my team, and she is wearing high heels now. She is not using a cane anymore. She is going back to work.
Wow.
And it's just amazing the
That
180
is amazing.
return
So
she
yeah,
made,
from
because when you saw her when she came in, oh, she also had a craniectomy. to relieve the pressure. I mean, it was big, major.
Mm-hmm.
And
So
you
she had
cannot
like a dent
compare
remaining in the side of her
another.
head from the,
Exactly.
yeah.
But looking at her now, you would not know she ever went through that. You would not know. There's no
Wow.
trace. No trace.
Wow. Wow. That's amazing. That's really amazing that, that we're able to support patients that way, that recoveries like that are really possible with movement and medicine and all the things.
Definitely. And we know,
That's so great.
just the power of mobility itself. Seniors in
Yeah,
particularly, when they're hospitalized, they usually
talk about
spend
that,
about
please. Yeah.
83. Yes. They usually spend about 83% of their time lying on their backs. And just to speak to the detriment of immobility when you are ill, it only takes 5 weeks for us to lose 50% of our muscle mass. So
Okay.
basically, 10% of your muscle mass, up to 10% of your muscle mass can be lost in a week. And that is very significant because a lot of chronic, complicated hospitalizations can go on for months. And if people are not being mobilized, they are at risk for deep pressure ulcers, which we already spoke about, urinary tract infections, pneumonia because of the stasis and the lack of mobility of internal body fluids. They end up with decompensated heart failure. Your oxygen capacity and your cardiovascular strength decreases because you're not moving and your heart's not pumping as efficiently. People have blood pressure issues. So when somebody finally decides to move them, their blood pressure drops so drastically because they've been lying still for so long. They get dizzy, they pass out.
Oh my goodness.
I mean, it's just a downward spiral. And if you just think, if you flip your thought process on people who are going through severe illness, rather than looking at them and saying, wow, this is terrible. I don't want to touch them. I don't want to hurt them. I don't want to disturb them. And if you just got a 50% muscle contraction, so you don't even have to do a full contraction, just try to ask them to move or mobilize them yourself. Prevent that decline that I talked about with the 10% of muscle mass lost by just doing 50% contraction a day.
Yeah, just a little bit of movement. Don't have to. Yeah.
So
wow.
So I
just
mean,
a little bit of movement.
Doing this in the ICUs, and there have been studies of people who go in and do therapy in ICUs, but it's not like a global tradition or a standard of care. There's special programs where they have going into the ICUs, but it's not a standard of care all around. So you don't see therapists going in and doing sessions with ICU patients on a regular basis. You
would have to order it as a physician and to know to order it.
I'm sorry?
Oh, you'd have to order it as the ICU physician and you'd have to know to order it.
Exactly. And a lot of people don't even think about it. So I'm saying this to anybody listening. If you are a physician in the ICU, please order therapy for your ICU patients. Just because they look so severely, traumatized or whatever the case might be, you are doing them so much service if you can get them moving. So much service. And their recovery will be so much more rapid, and the quality of it will be so much better.
Yes. Yeah, it's just so important to move, and it's so interesting to hear just how that manifests in these like acute illness situations, that it's just all the time.
Yeah.
There's not a time that's an exception to that. And I guess maybe arguably it's more important because in these situations you really help people preserve the strength and robustness of their body.
Exactly. Because they can't, in some cases, they can't do it for themselves. They're not even, they're in such a dire state. Someone has to come with the know-how and say, we got to get this person moving, even if we're just lifting their arms and bending their knees, turning them every 2 hours, turn. So many
Mm-hmm.
Pressure ulcers could be avoided if that happened on a regular. But again, we really have a staffing issue too. So that's a challenge. It's hard. It's hard to go in
Yeah,
there
a lot of challenges all around.
and do that. Yeah.
Well, I'll wrap us up here soon, but as a physiatrist, obviously you're very knowledgeable about motion and, moving to keep the body healthy. As someone who treats patients with chronic pain, sometimes if I'm speaking with a patient, they'll say, oh, doc, I've never benefited with physical therapy, or it just, it hurts too much. I can't be active. How do you talk to patients to kind of reframe some of these ideas that, so patients can feel empowered to move as much as possible? How do you approach those types of objections when patients have a pain problem?
Right. So I address the thoughts first. We have to start there, because if you believe that you cannot move because it's going to be too much pain, you will never do it. And sometimes we have to accept that there will be some pain involved in the movement, but the outcome of working through some of that pain is going to be so much better than that pain that you're enduring for now. And I use the analogy of childbirth, where, that's excruciating pain. If you ever had a child, it's excruciating pain. And there is a hope at the end of that you're going to have a beautiful, healthy baby that's going to enhance your joy on the other side. When you're going through it, it's miserable. You're cussing, you're screaming, whatever. You hate it.
Right.
But there's something on the other side of that to look forward to. So I try to help my patients, hope coupled with skill and knowledge is my approach. And if we can get you to the hope, because a lot of people have lost hope, and the cycle of chronic pain with depression, it all comes down to, I don't have any hope that this is ever going to change. And that's the roadblock that you set yourself up for. So we have to get to a place where we can visualize what life would look like if I could just get from this bed to the bathroom. I'm not asking you to get downstairs out the door to the lawn yet.
Yeah.
I just want you to envision getting from this bed to the bathroom, and just think of how much greater your life would be if you could just take yourself to the bathroom. We'll just start small, but I want you to start visualizing that so you can see it. Because once you can see something in your head, then you have something to work with. So that's my approach. We really have to start with the thoughts, because if we can't
I like this.
come up with a better way, a better mindset, we're not going to get anywhere.
Yeah, and just starting with that visualization, like it's one thing to, calling out the fear or the thought, but really to encourage that patient to visualize it. I think that's exciting, and we know that can be effective in athletes, and that's super interesting to think about as a strategy, for a patient who's having a pain problem.
Yes.
All right, my husband has started to vacuum, so I think it's time to
Okay.
I don't know if you can hear it, but
that's a wrap now.
But Samantha Benjamin-Allen, thank you so much for joining us. It is lovely to meet you, Prince George's County native and Washington, D.C. native. And for my folks that are watching, particularly in our area, this is a wonderful resource for you. We've got her contact information through her social media, Facebook and Instagram and website. So please reach out. Dr. Benjamin-Allen, thank you so much.
Thank you for having me, Dr. Merritt. It's a pleasure. Bye-bye.
All right. Yeah. Find us at Livestream, everybody. Call us if you need an appointment, 301-860-0305. Thanks.